what you hear from any organisation on that quality improvement, quality management system journey is that if you haven't got the board and the trust executive really invested, speaking as one, visibly backing programmes of improvement, then it's just going to wither.
Meet Andrew Hines, the Chief Executive Officer at Surrey and Sussex Healthcare NHS Trust. He brings a long career in NHS management, recently served as Executive Director of Group Development at Barts Health NHS Trust. He brings deep expertise in system integration, culture change, and neighbourhood health.
We are essentially a people business. It's hard to think of another industry where there are so many disciplines working together with a really high degree of autonomy and carrying a really significant level of risk. I think the bit in an operating model that can tend to get less attention but is really important in the NHS in particular is the leadership behaviours and culture aspects.
If you were giving advice to somebody else who was thinking about their operating model and when it was like, oh my goodness, I'm not sure it quite is fit for purpose, what advice would you give?
I think having a
Well, good afternoon. Thank you so much for joining me, Andrew. So Andrew Hines is the recently appointed Chief Exec of Surrey and Sussex Healthcare NHS Trust, following a long career in NHS management. Most recently, he was Director of Group Development at the Barts Trust. And before that, he had worked for NHS Improvement, the London Region, the Trust Development Authority, and had roles in provider organisations before that. So it's really appreciative of you joining us on the podcast this afternoon, Andrew.
real pleasure, Alastair. Really good to see you.
And you've recently started at Surrey and Sussex Healthcare. Do you want to tell me a little bit about the organisation?
Yeah, 8 months in, and name is slightly misleading. We're not running services for the whole of Surrey and Sussex, but we do sit right in the middle of what is now a single integrated commissioning board organisation, and we are essentially a really busy district general hospital serving a population of around about 750,000 people across East Surrey and West Sussex, operating predominantly out of the Red Hill Hospital, East Surrey Hospital site. We also have satellite hospital services in other locations. We aspire to delivering really high quality care to a local population and to the increasingly working in a much more joined up way with our GP and community service colleagues.
Thank you. That's great. Well, I think we'll get a chance to explore some of that as we go on. But the question I'd like to start with, which I ask almost everybody, is, what do you understand by an operating model?
So for me, just keeping it simple, it's about how we organise ourselves to deliver the strategy of the organisation, as simple as that. I don't tend to do a lot of reaching for management models, but what I've found quite useful in the past is the Galbraith star as a way of just kind of describing the kind of the moving parts. And that talks about strategy, people, structure, processes, rewards or motivation as the various kind of aspects of an operating model. My experience is we tend to think about the stuff you can write down, the structures, the processes, the kind of leadership arrangements, the governance. I think the bit in an operating model that can tend to get less attention but is really important in the NHS in particular is the leadership behaviours and culture aspects. We are essentially a people business. It's hard to think of another industry where there are so many disciplines working together with a really high degree of autonomy and carrying a really significant level of risk. So how those individuals interact with each other and work to deliver the objectives is really critical without the kind of close day-to-day supervision. So I think for me, getting the behaviour and culture right in any organisation as a really critical part of the operating model is, if anything, the most important part, but it's the part that is hardest to capture and codify.
I think that's a brilliant observation. We often talk about how bringing the overall organisation design together with the leadership system, the kind of framework you create within which leaders in your organisation can thrive and do their best, whether they're clinical leaders or operational leaders or in corporate services, is so important. And as you say, often neglected, that piece about culture and behaviours. As you've come in, as you said, you're 8 months into a trust and you will face many of the challenges that acute hospitals face. What are the biggest challenges you're facing and how well do you kind of feel like you've inherited has organised you to meet those challenges?
Well, as you say, Alastair, there's an NHS context for this with a set of challenges that are shared by many. So what you could describe as the cumulative impact of a number of years of austerity, post-financial crisis and then the effects of the COVID pandemic. So, like all acute providers in the NHS, we are recovering from the pandemic and progressively reducing waiting times for both urgent and elective care. I suppose specifically for my organisation, the kind of top three challenges will be, first of all, emergency flow. We are a very busy, congested site. We need to decompress our emergency department to provide much better care to our patients. And that front door pressure, particularly patients with mental health conditions, combined with the challenges around length of stay and discharge, just means we were very, very busy district and hospital, and we need to shift as much work as possible off the site rather than continuing to suck referrals and activity in. Second challenge linked to that is around financial sustainability. We've seen, again, like a lot of the NHS, significant growth in workforce over the last 6 or 7 years, but that growth in workforce hasn't been matched by an increase in activity and income. And therefore, that's put us into a challenging position in terms of financial delivery. And then the third challenge for me, which in some ways underpins that, is culture, as I was describing in terms of the operating model, that we've had a period where staff have post-COVID felt less valued, less able to speak up, less able to raise concerns. And that's been reflected in staff survey and a variety of other ways of listening to staff. So a key priority for us is to ensure that our staff feel engaged, listened to, able to make improvements, and they've got the tools to do that. I think if we can get those three areas working in harmony, then we'll have an organisation that is both delivering today's standards effectively, but is also responding to the government's agenda over the next 5 to 10 years in terms of the three shifts from acute to community, treatment to prevention, analog to digital. And I think we'll be in a good position to take all those things forward. I think the final thing I'd say, really underpinning all of that, is around partnership working. So have, I think, historically perhaps been seen as a bit of an island within quite a big complex system. And pretty much everything we do, whether it's around flow, whether it's around financial sustainability, requires us to work in a much more hand in glove way with community providers, social care, voluntary sector. So a lot of emphasis on what neighbourhood working means for us in our Surrey and Sussex catchments, and how we can be an effective partner, and what it means to potentially step into an integrated health organisation type space where we are taking on a kind of broader role around population health and population budgets.
Maybe we'll come back to the specifics of that. But I know within your trust, you've also had a big emphasis historically on your kind of quality management approach, haven't you? And so do you want to say a little bit about what it is you found as a kind of legacy, and then what it is that you think you need to do to develop that, take it going forwards?
One of the things that we're really renowned for and known for at SASH is our quality improvement, quality management system. And that journey started 10 years ago, back in 2016, when NHS Improvement offered the opportunity for a number of organisations to partner with the Virginia Mason Institute in Seattle. And that's a hospital organisation that had really prioritised delivering the highest possible safety in terms of patient services, using lean manufacturing processes taken from Toyota and other industries. We embarked on that 10 years ago and have been aspiring to a world-class management system. And that's got a number of pillars within it. Broadly, it's around balancing vision and strategy with values-led leadership, management systems that are measurable with high levels of accountability, and an engaged workforce. And if you get all those different pillars working together, then what you have is an organisation that is strongly clinically led, where staff at all levels have got the training to make improvement. You've got people working across boundaries with each other and making connections across different disciplines and different levels of seniority. You've got highly visible leadership. You've got a systematic approach to production boards and huddles and some of the kind of Japanese language around Gemba walks, so visibility at the front line. And I think we've been on a sort of 10-year journey to mature that. And I think where we are now is that we've got a really high level of recognition of that across the organisation, universally positively regarded. Lots of staff who've been through the lean training and passionately enthusiastic about it. And that has driven historically really high levels of engagement, and really satisfied staff, and significant improvements in terms of delivery and standards. The challenge going forward, we may want to explore this further, is how you then take a system that was essentially designed to be bottom up, inch wide,
Yes.
mile deep, an aggregation of lots of small changes. How do you apply that approach to the really challenging context we find ourselves in now, where there are the big transformational challenges around, for example, how outpatients might be redesigned for the 21st century, and how might you apply those principles and that kind of methodology to the big scale, at pace, top down change without losing the benefits of the bottom up engagement and the value of staff feeling really invested in the approach.
And I think absolutely it's a challenge. Tricordon's 21 years old this year. And when we were founded, one of my co-directors had been a lean systems engineer with Lucas. So from the beginning, we were looking how we could apply some of the kind of lean systems thinking in healthcare. I think things have come a long way, and examples of hospitals such as your own have shown how it can be culturally appropriately embedded. And Virginia Mason is an inspiring place, and the stories there are inspiring. So, but I do think the nature of that continuous improvement bottom up meets top down strategic challenge, and how you bridge those two is a fascinating challenge. So have you got ways, do you think, that in terms of how you're operating, you effectively is going to allow you to sort of bring the learning and the processes and the approach of your quality management system into, outpatients, transformational, UEC, etc.? Have you worked out how you think that's going to happen yet?
I think we're still learning. We've got a few things I think we have taken from what's worked well and what's worked less well in the past. The principle about just a high level of staff engagement and engaging staff at all levels in a change, I think absolutely translates into the big ticket change. So, staff will talk about how bringing porters and consultants together in a change project is not the kind of typical way the NHS delivers change, but actually is really, really powerful. So I think that high level of staff engagement and the support to do that, the high level of patient engagement is also kind of designed into a quality management system, and something we often struggle to do well and consistently in the NHS. I think there's also something about not being too rigid with the tools you use. There was, I think, in the kind of earlier days, a bit of a sense you had to do it in a very standardized way. And the way you delivered change was through, for example, a 5-day rapid process improvement workshop. And of course, that's expensive in terms of time out of the job on a particular program of work. So I think being adaptable, where you can take the kind of the principles of some of the tool and the method and then adapt them to the situation, and not be too prescriptive in terms of saying it has to be done this way. So I think we're still working that through. The thing that I think is a non-negotiable is the top level commitment. So what you hear from any organization that is on that quality improvement, quality management system journey, is that if you haven't got the board and the trust executive really, really invested, speaking as one, visibly backing programs of improvement, then it's just going to wither. So yeah, I think we're still working out how you do this and how you bring the approach to some of the top scale change. But what we are doing at the moment is realigning our transformation team from being a team that is about coaching and training to a team that is able to lead programs of change from a sort of a larger perspective. And that will hopefully help to bridge the gap between the bottom up and the top down.
I mean, so effectively what you're describing is an adaptation and a modification of your operating model, how you're organizing, but focused very much through a quality management system. And I guess if colleagues have got trust in that and a shared understanding, a shared vocabulary, then I guess it makes some of that change process easier. And also, as you say, you don't necessarily need 5 days out for a Kaizen blitz or a rapid improvement event, because people know, would trust bits of the processes they go through. Are you feeling like this operating model that's emerging for you, that is now going to be able to do top down and bottom up, is kind of emerging and developing, in a way you think, yeah, this is going to be able to deliver the changes we need in the timescales we need? Because I guess that's the other thing, is it's a pretty, as you know much better than me, unrelentingly demanding context in terms of services and finance in the NHS, particularly the acute world at the moment.
Well, I think the challenge for us in the context and for any organization thinking about, a quality management system as part of its operating model is it can feel quite daunting. If you're looking at what the kind of idealized world-class management system looks like, and then you look at the kind of lived reality of corridor care and, a battle to deliver, 5-6% cost improvement programs, it can feel really, really challenging, particularly when there isn't the kind of resource there was around 10 years ago to work with partners to deliver it. I think what we're reflecting on in terms of going through a bit of a kind of refresh and reinvigoration at the moment is how do you describe the journey in a way that feels less daunting? So what do we do in the next year that will get us to a better position in terms of executive visibility and how we're using our transformation resource, and how we're better embedding statistical process control ways of measuring performance. And so what does an increased level of maturity look like over the next year? And trying to describe that journey over sort of 2 or 3 years that recognizes there is a kind of nirvana that can feel quite overwhelming, but actually these are the ways it can help in the here and now. So an example for us was, we are in the process of designing and building a new urgent treatment center at the front end. And we could choose to do that in a fairly traditional way in terms of how we design and build these things. We've very deliberately used our SASH Plus quality management process to have quite an extended period of engaging with staff in that design process and bringing partners together into a workshop. And we very explicitly kind of badged it as a kind of SASH Plus approach. So I think very visibly using the kind of methodology for really high profile projects like that, I think just helps to reinforce the organization's commitment to working in that way.
One of the key things about success for NHS trusts is about continuity of leadership. And obviously, it's interesting that you've come in and what you've chosen to do is to take something that's been there for a long time and it sounds like reinvigorate it and refocus it for the challenges facing you rather than, as it were, stamping your authority by saying, here's something new that I'm bringing. So this thing about, particularly when you're a new chief executive or a new leader is, what am I going to build on and bring continuity to, and where am I going to change it and put new emphasis? So do you want to say just a little bit about your approach to that, Andrew?
Yeah, that's a really good reflection, Alistair. So I think there is a danger, isn't there, when you come in as a new leader, that everything that your predecessor did is kind of devalued and you start again. And we just don't have time to do that. From my point of view, we've got a strategy that is largely fit for purpose, that is well recognized by staff, and there is real value in showing a long-term commitment to a small set of strategic objectives. So we've retained our commitment to being, delivering safe care, outstanding place to work, working in partnerships, financially sustainable patient outcomes. That's, we've maintained continuity with that. The commitment to SASH Plus is something I think that has been built up over many years. Set that aside lightly. But what I did make a point of doing was listening and understanding the areas where change was needed. And that was particularly around listening to valuing staff and creating psychological safety. It was about visible executive leadership, starting with the chief executive. It was about getting behind SASH Plus and showing commitment to it and role modeling that. And it was about, refreshing leadership and making sure we have the right people in the right roles to deliver the agenda going forward. So I've tried to kind of come in and, spend the first 2 or 3 months just listening to what the organization values and what we need to do differently. I had the benefit of a number of, external views. We had a well-led inspection in my first couple of months. Probably not the timing of my choice, but that was quite helpful as a way of just acting as a catalyst for the organization to get us to reflect together on what was working well. And as a result of that, the areas we know we need to work on are around listening to staff, equality, diversity and inclusion, and embedding our changes in governance.
Right. Okay. No, that's interesting. I've got 2 particular questions that are running in my head at the moment. And maybe we'll start here. Is that obviously you've come into Sussex from previously being at Barts, which is a route model and very different. And I previously interviewed Shane DeGarris, who was the group chief exec, and obviously you know Shane very well. I mean, my sense is probably the 2 organisations and the challenges facing you are very different, but you've got that lived experience. So I'd be interested in how you'd reflect on, what's different about the organisations, but also what could each learn from each other.
Yeah, it's a fascinating comparison, and I was really fortunate to spend 8 years at Barts Health, and when I joined it, it was in a position where Many were questioning whether it had a future as an organisation, given the real difficulty it got itself into post-merger. It was brought together from three separate organisations, as Shane would have described to you. I mean, essentially, the big change in the operating model there was the organisation previously got a very centralised model, quite a traditional one. When you merge organisations together, you just put structures in place that work across horizontally. So the divisions were working across the different sites within Barts Health, and there was no focus on leadership at site level. And what that led to very rapidly was a sort of loss of focus on quality and financial delivery at the level of the individual sites. So the key intervention there was around a matrix operating model, group operating model structure, with a combination of devolved leadership at site level, running the services operationally day to day on each of the constituent hospitals, but then a really strong set of horizontal mechanisms around bringing clinicians together in networks and clinical boards to agree strategies for their services, to set standards, and to try and get the best of working as a group. That's a complex model to pull off. It made demonstrable improvements in terms of the trusts coming out of special measures, really impacting on the underlying financial deficit, being recognised as a kind of exemplar in terms of group models, as group models are spread elsewhere in the NHS. Barts, like SASH, has been working on a quality management system, both organisations approaching in slightly different ways, but with the same principles. So Barts worked with the IHI, SASH has worked with Virginia Mason, but the same underlying principles. And in some ways, both organisations are not in dissimilar places now in thinking about what is the step up from a quality improvement system into a proper world-class quality management system. I think there's some reflections each organisation could potentially share with the other. So I think from the Barts point of view, what I think is helpful learning is to continually evolve the operating model, set it in stone and believe you fixed it, but to recognise the context is always changing and the maturity of the model itself will evolve. And what happened at Barts was that the devolved leadership teams within each of the hospitals became confident to take more on. More services were devolved out to the site leadership teams. Then more attention was needed to manage the tendency for the hospitals to kind of go their own way and to sort of hold together the group by reinforcing those mechanisms around how, for example, elective capacity is used effectively. That ability to kind of constantly learn and evolve the model and be quite reflective on what's working and what's not. If SASH had anything to teach Barts, it would be that leadership commitment over an extended period of time is really, really important. And I think, Barts knows that. I think they've got a very stable leadership team, but I think what SASH saw was that a change of leadership and turnover can be quite disruptive. And if you don't really pay attention to that need for the executive to show continued commitment over a sustained period, irrespective of key people turning over, then it's quite easy to go backwards. And what I'm doing at the moment is ensuring that as an executive and as a board, we are clear about what SASH Plus is for the next 5 years, and we are properly invested in and committed to doing that.
Thank you. And I guess part of the connection is, as a single main site kind of DGH provider, some of the bits that the group model in Barts would have working across other providers, it will be in the acute provider space and in the working in the wider context in Surrey and Sussex with other providers and other system partners. So do you want to say something about how your operating model fits into the kind of evolving system that you're in? Because you've always been in Surrey and Sussex, but you're now more conveniently, I guess, it's come back to be a Surrey-Sussex IT. How's that fitting? Because it's a changing environment. I mean, just today, we're recording this the day after that we've just had elections for the East Surrey unitary local government being established. So I guess there's going to be quite a lot of changes happening locally. So how does SASH fit in that wider evolving system?
I should say an awful lot of change. The local government review, meaning big change in both the Surrey and Sussex systems, with still a bit of uncertainty about how the Sussex system will write this through. Surrey ahead in terms of the East and West Surrey unitary authorities. ICB coming together, NHS England going through its change process. So, as is often the case in the provider world, there is greater stability when everything around is changing in terms of commissioning and regulation. And I guess for us, it means being quite thoughtful about how we work horizontally and vertically in terms of partnerships. So horizontally, we've got some pretty well established relationships within the Surrey patch in terms of a provider collaborative and a set of reasonably mature programs looking at both clinical areas and non-clinical, where we think we can do things differently by working together. And on the Sussex side, a newer provider alliance, very much focused around kind of outpatient single point of access, how we think about maternity services, how we think about some of our corporate services. So I think two different models, but the key thing in both, I think, is good relationships, a high level of trust, chief executive commitment, and a real desire to make measurable change rather than just be in a room paying lip service. And that isn't always the case, I think. So I think that's really encouraging for me. Complex bit is the vertical integration, I think. In recent years, like many acute trusts, we've been fairly focused on our own business, have spent less time building relationships with primary care, and some of the areas of joint work where our clinicians have been working closely with GPs have perhaps lapsed for a variety of reasons in recent years. So we're working through in both systems what the neighbourhood models look like. In East Surrey, we are part of one of the pilot neighbourhood place developments nationally, one of the 40 or so. So we're looking at how we can work together with our community and primary care providers on frailty, on cardiovascular care, on metabolic medicine. In Sussex, we've got a slightly different landscape, and we're working through our three most immediate sort of places around how we deliver together a reduction in avoidable non-elective admissions. So what I am conscious of, though, is as a relatively small to medium size NHS provider, we've got to be quite purposeful about where we invest our time and effort and where we think it's going to have the greatest impact. Danger with some of these things is they can have quite a long timescale associated with them, and we all know that kind of left shift is not a new concept, but it's often measured in years rather than months. We're kind of using a bit of a burning platform in the sense we've got a need to close a couple of wards around kind of fire compliance issues, and that's actually a really helpful catalyst for change, because rather than just re-providing those wards in another location, we're looking at how we can reinvest some of that resource to promote, for example, an increase in virtual ward capacity and better management of frailty patients to avoid attendances and an expansion in same-day emergency care. So I think we are using what could have been a bit of a crisis to actually drive change faster than otherwise might be the case.
And I guess in doing that, you've got to work both with those partners in primary care, GPs, your community providers, social care, but also your own clinicians. And I guess there's a bit of a not quite trust issue, but our confidence issue as to whether those changes really will reduce enough demand that we won't need those 2 beds. And the patients, as we always know, overflows into surgery. And I'm sure if you remember back early enough in your career, all of those medical outliers that meant all your surgical patients were cancelled. So, which is the stakeholder groups that are kind of most challenging? Is it your internal clinical body saying, hang on a sec, I'm not sure this works? Or is it external partners? Or are you processes taking you confidently together, do you think?
I've not picked up any antibodies to working in a more joined up way. I think all clinicians I talk to absolutely get that. And in many ways, have worked in that way in the past to a greater or lesser extent. What often just gets in the way is that people's job plans are already fully committed. When they can see a hospital that's operating at the highest level of escalation a lot of the time, their focus is on dealing with what's coming in the front door today and managing current inpatient demand. And it can be quite difficult to see a way through to where job plans could be changed to have sessions working, with GPs in a different way. So I think it's not a will issue, but in some ways it's trying to connect the things we want to do in terms of neighbourhood working with how that's going to make life better today. So how will working differently with GPs and working differently to manage patients in virtual wards reduce front door demand and make a difference in the here and now rather than 2 or 3 years now.
Yeah. As you say, you want to jump that development curve that we know usually takes time. You're leapfrogging some of those development. That has been done. We know we've seen in other industries, I think of mobile banking for in places like Kenya, for the Maasai, leapfrogged where we were in this country for a bit. So, but it's whether you can create the conditions and orchestrate the kind of stakeholder engagement that's doable. But as you say, you have a burning platform. Well, hopefully not a burning platform.
Not literally.
You have a challenging situation that's driving that hopefully focuses management and clinical attention. So, and that's interesting. So, what you're doing with your local neighbourhoods, particularly in East Surrey, is so obviously the long-term 10-year plan is talking about integrated, healthcare organisations, IHOs, and do you think that that's a possibility for East Surrey or even for Sussex? How are you thinking that might work through locally?
Well, it's something we're debating and discussing as a board at the moment. We don't want to chase IHO just because it's fashionable, just because it's the policy. And you can get into difficulty, I think, if you chase an organisational form and kind of lose track of why you're doing it and lose track of what's important. But I think for us, we can see a different way of working with our community services. It doesn't necessarily mean having to run community services ourselves, but we could see that perhaps holding a population budget and then contracting, commissioning those community services could be a really effective way of working differently with our community partners and levelling up in both of the systems that we operate in. There is a license to operate, I guess, in terms of the system being prepared to trust us to take on an IHO role. So we clearly need to work on our financial sustainability, delivering the constitutional standards and providing high quality, safe services as the kind of license to operate. So we are very aware there is some work to do before it will be a realistic proposition. And the other thing, of course, is that the skill set you need to be an effective IHO is somewhat different. And both at Barts in my previous role and here at SASH, we do actually have some expertise in terms of population health, public health, and outcomes. But that's not true of every organisation, and that would need scaling up if we were going to become an IHO. But I think for us as a sort of medium-sized organisation, then there are strategic choices. Do we stand alone? Do we become part of a group? Do we form an IHO for a Surrey and Sussex catchment? And I think that IHO model is the one that would feel the most able to deliver benefit to our patients. And I guess that's got to be the ultimate goal. It's not about organisational sustainability or viability. It's about what is the best way of organising our services that's going to deliver the outcome for our patients.
Which is all then about value and value-based healthcare. And I guess the issue of what scale of geography you think, because you mentioned that might be bigger than just, that there must be a kind of relationship between the geographic size of something. So in terms of the kind of actuarial risk of a provider for a population, it's enough without being too many players and too many relationships that you don't form, which I think you need for the sort of integration and bold need if you're going into an IHO. So is that still part of the discussion, the kind of what's the geographic footprint for this, or is the natural tendency towards a Surrey Sussex level?
Well, I think in our geography, we are, pretty much a fixed point as a necessary provider of at-scale emergency services and elective care. So we're not in the position of perhaps some smaller DGHs, particularly coastal, where there are just questions about configuration. Fundamentally, we need to carry on doing what we're doing in terms of the range of services we provide, but provide that in a more integrated fashion. So I think for us, there is probably no single definition of what is a viable IHO, because there is a degree, it's context dependent, isn't it, on geography and provider configuration. For us, a population of 750,000 is significant. A population that spans Surrey and West Sussex, constructed around our catchment, does feel logical when we look at it alongside our neighbours. So from that point of view, I think we can see a kind of credible IHO proposition. It is a complex provider landscape. So, on the Sussex side, we've got a single big NHS provider of community services operating at scale across a large part of the county. Whereas in Surrey, we've got a sort of patchwork of community interest companies, services that are managed in-house, services provided by the independent sector, and services provided by GP federations. And so that landscape is pretty complex to get effective partnership working, and that's a challenge. But I think we're now in a place as an organization where we can provide a leadership role into those systems that I think would be welcomed rather than being seen as maybe it has traditionally, where acute trusts are seen as having, tanks on lawns and just looking to suck in community services and not understand the services that they're providing. I think we would now be much more credible within that kind of quite complex landscape in holding that role. But I think the important thing is to start with, what are you trying to do in terms of patient pathways, rather than the starting point being prime contractor models and financial flows and governance and all the stuff that needs to enable that to happen.
Yeah, which is probably back to what you said at the beginning about, organizing to deliver our purpose and the strategy about healthcare for the population. And it's all about relationships and culture. And I guess also the fact that you're being forced to make those service changes and investments of investing outside of the acute kind of classic model and supporting more community-based care all will help in terms of signaling to partners, we're serious about being part of a integrated community provision, not we've got to keep sucking up the resources. So yeah, that's interesting. So I'm really intrigued because as you describe it, across Surrey and Sussex are very, very different, healthcare systems. I have family who live in the area who have used your hospitals quite often, quite a bit. And so I've certainly heard the stories of improvement over the years. But do you want to say a little bit about what the experience of working in Surrey and Sussex is as to how what's the contrast between those two different systems? And now how do you, I guess, use the opportunities of what each system brings that's different, but also knowing you've got a single ICB working? I mean, how are you going to navigate that?
We see quite clear postcode-based differences for our patients around, everything from the front end through to the back end. So if a patient arrives in our ED with a mental health condition, then we're talking to two different mental health providers who are, both excellent, but have, somewhat different models in terms of their crisis services, in terms of how they manage their inpatient requirements and the extent to which they have capacity to meet those needs. So different mental health models, and we have to think about how we provide a kind of single front door assessment and then relate to those different models of mental health care. In terms of discharge, we've got a Surrey Home First service that has been really refined over the last year that is, I think, really now demonstrating benefit in terms of shorter length of stay and reducing some of the patients who don't have criteria to reside. Different model at the moment around discharge planning for complex patients in Sussex. And Sussex is one of the most challenged systems in the country in terms of the proportion of patients with no criteria to reside. So we are working with Sussex partners to try and make those improvements, but clearly would want to try and see greater convergence of approach. And we've got a key role in terms of sharing what works across, whether it's about mental health or about discharge. There is a risk for us that we can externalize the problem. It's quite an easy excuse sometimes to say, well, we've got two catchments with two different ways of working, and if only our partners will get their act together, then all will be well. And while we want to be working really positively with our partners, we've got to demonstrate we're taking responsibility for the things that are within our own gift. So, putting in your urgent treatments and tackling our pathway zero patients in terms of discharge and minimizing length of stay there, maximizing our use of same-day emergency care. I think if we can demonstrate we're doing all those things, it gives us greater credibility to then talk with partners and ask them to step up in the areas that we would want them to.
Great. No, thank you. I mean, it sounds like, Andrew, that without doing kind of dramatic change, you are continuing to develop and evolve your operating model, particularly through the SASH Plus quality management system, but then also how do you work with partners across the wider systems, and how do you think about what the future strategic position would be? So it sounds like there's a lot of change without it being, I was going to say dramatic or sudden, but it feels like there's a strong evolutionary development course that you're following.
Yeah, this is what I said at the start, really. It's less about structural change and lines of governance, where a lot of work had been done before I started. But I think what people are reflecting back to me in terms of what they're seeing that is different is a very different external engagement, where the trust is a very active partner and a very willing partner in both systems in which we operate and is looking to play a full role. And I think that wasn't because there wasn't a lack of will in the past, but I think I put a lot of emphasis on that kind of messaging to the organisation and role modelling, that we need to be working in a very system orientated way. And that kind of comes naturally to me from working at Barts, where Barts itself is a system within a system, working on the scale that it is. I think the other key change, culturally, is that sense of giving a positive vision to staff and a clear expectation that leaders are working in a particular way. And I talk about, compassionate, inclusive leadership. Personally, put a lot of time into making sure that our staff networks are effective and being visible around the organisation. So I think for me, it may be less dramatic than a major restructuring or writing a new organisational strategy, but tackling those cultural aspects and the partnership working are really, really important in terms of getting the organisation to a different place.
Yeah. Well, and as they say, those things are sometimes called the soft things, but they're the hard things. I would say the evidence base for the impact on performance, whether that's staff well-being, patient outcomes, or hopefully the financial result, is very, very strong. But it's tough and difficult. So yeah.
Well, I wouldn't want to give the impression it's just about the soft stuff. I'm putting the emphasis there because often it gets underemphasized.
Yes.
On the harder stuff. On the financial side, we've had divergence over a number of years of budgets from rosters. We are proportionately the highest user nationally of temporary staff, because our establishments and rosters have got so out of step. So we put a lot of effort through our finance function into strengthening our finance function, different approach to budget setting, making sure we've got assurance around safe staffing and safe staffing reviews, and then going into a new financial year being much more confident we can hold staff to account for the budgets that they've got. So those are, really fundamental enablers that sit alongside some of the kind of softer stuff.
That's interesting to hear. And do you just want to say a bit about, clearly AI and the opportunities that AI might be bringing to organizations, as to where you are and how you're finding that's fitting into kind of the situation at SASH, because you've got a reasonable digital legacy again that you're dealing with, or how are you finding and what do you think the opportunities are there with the kind of AI?
I think, you've got the foundations right, haven't you, in terms of that the staff can't see that is resilient and stable around the kind of boxes and wires. And I think there's been a lot of work on making sure that infrastructure is resilient, effective cybersecurity arrangements in place, and that can hardly need emphasizing in terms of one of the kind of conditions to then build on. So I think making sure you've got all those foundations in place, and it's really noticeable coming here to SASH that I don't get anyone complaining to me about not being able to log in or downtime. Wow, that takes a lot of work to sort of get those foundations right. So I'm really proud of what the team have been able to do over a number of years to get to that point. In terms of AI and where we're at, I think it, like most organizations, it feels at the moment still quite patchy and dependent on enthusiastic amateurs. So we've got, we can see that ambient voice technology in outpatients could be really, really transformative. That's something that we want to take forward through our digital strategy. Copilot licensing is available across our corporate services, but we haven't standardized how we use Copilot as a tool to improve the efficiency of our corporate functions. And I think the other area is linking it to partnership working, scaling up our corporate services, like our recruitment function across multiple organizations, and then using AI to enable automation of a lot of those processes is where I think doing things with other providers rather than on a standalone basis will be a more effective way forward. We've got a really good network of CIOs working within our patch, and I think we would see the kind of engine room as being the CIOs coming together across multiple organizations and trying to take forward AI at scale in key corporate areas.
Final question then is, if you were giving advice to somebody else who was thinking about their operating model, and when it was like, oh my goodness, I'm not sure it quite is fit for purpose given the scale of change and the demands facing me, what advice would you give?
Well, you haven't paid me to say this, Alastair, but I would buy in some external expertise to help make it happen. because I think it does require some experience of doing it, in a number of different places, number of different settings, and bringing the learning. So working with external advisors who can help with that, I think is really helpful and a good investment. Linked to that, I think having a framework, Galbraith style I mentioned earlier, different kind of mental models, but having a structured way of making sure that you're balancing off the different components of the operating model and paying attention. And then the third thing for me will be around leadership development. So, going back to Barts Health, when we put in the group model, the matrix way of working is quite different and quite challenging in some ways, expecting people to wear different hats in different places and to be working collaboratively with people you don't have line management relationships with. So I think investing in the kind of leadership development about both the behaviors that are expected within the model, but also how you build relationships with people across different boundaries. I think that kind of leadership development, team development is a really important enabler to success.
Brilliant. And I love that you've referenced J.K. Galbraith twice, one of my heroes of org design. I was privileged enough to meet him. Really humble, wise guy. That's really helpful kind of advice you give. And thank you so much for your time, Andrew. Really appreciate you sharing your thoughts, and all the best with the development of SASH going forwards. Thank you.
Thanks so much. Real pleasure talking to you.